control interventions such as the treating of the water sources, the adoption of hygiene practices, and acceptance to go to treatment centers, as well as acceptance of the oral cholera vaccines. So the RCCE is very, very critical because it places the communities at the center of the response. The second issue is about our oral cholera vaccine, which by the time it came on board has been a very critical tool in helping us respond to cholera outbreaks in the last decade. However, we have had some challenges because of the number of outbreaks that are being dealt with and the demand for these oral cholera vaccines, that we have had a change in the strategy. And so the latest information and guidance and how to do these reactive vaccinations will be provided to you today. And lastly, cholera control is a very resource-intensive exercise. And there are a number of supplies that we need to be able to effectively manage cases. And this has been made easy by formulating these into kits. And these kits, you will be receiving an overview of them so that when you request to the WHO offices within your countries, you know what kit that you are requesting for and how many patients it can treat and what are the contents of those kits. So it's a very, very important session. And these tools at our disposal in terms of the engagement with the population and increasing their risk perception, the deployment of a reactive vaccination campaign, and then the availability of the cholera control supplies are very, very key arms of our response approach to cholera. So I wish you a very informative and interactive session today, and I hope you have really gained value in terms of knowledge in the last 3 sessions, and we hope you can be able to effectively support the responses in your different countries. And so if I am not available for the last session, last part of this, I would like to encourage that we continue to participate in this webinar series so that we ensure that we have a complete set of understanding, both in terms of the response, but also implementation of the long-term interventions to eliminate cholera within our region. It has been done in other places. We can also be able to do it within our region. So thank you very much, and over to you, Dr. Paula.
Thank you so much, Dr. Patrick, for those words introducing the session we'll be having today. We also thank colleagues for joining this meeting, and the key areas we'll be speaking on has been highlighted. So we'll go to the first one in this session, which is on risk communication and community engagement during cholera outbreaks. So this will be taken by Susan Nyawade. So Susan, the floor is yours. Over.
Thank you very much, Dr. Olaolu. I'll go ahead and share my screen. I'll be representing the risk communication and community engagement team. We may be on the call with Aminata Kobi. For me, as has been mentioned, I'm Susan Nyawade. I'm based at the Nairobi Emergency Hub, part of AFRO, and I'll take you through the few slides that we have on risk communication and community engagement. Just to mention upfront that the focus today is going to be on response and control, and at a later date during the next series of the webinars, we will be talking about preparedness and readiness. So if I focus more on what happens during response, do bear with us. So in terms of the outline, we'll be looking at the overarching goal and strategic objectives for RCCE. This is more global than maybe specific to this webinar. We want to understand why risk communication and community engagement, especially during the response. And in this case, we'll just have a select areas to talk about. The principles of community engagement are key because everybody engages with the community at one point or another and in different settings. and then how to communicate, and eventually we conclude. So in terms of the overarching goal, we ensure that people-centered and community-led approaches are championed widely, because when we are talking cholera prevention, cholera response, we are interacting with people, as these are the people who are presenting with the cases, and therefore we need to be able to guide them. And this would therefore result in increased trust and social cohesion if we speak to people and, most importantly, listen to them. And this is expected to reduce the negative impacts of most public health emergencies, where cholera is among them. So they need, in terms of the strategic goals, where these activities need to be community-led. That is the only way that they'll feel part of it, and this is important for continuity. We are saying that, yes, we have outbreaks, but we must continue to contain and also promote practices that will prevent additional outbreaks. And if we have people within the community who can lead these activities or interventions, then this helps in the consistency in what we need to be done, and also the ownership. They need to be data-driven and evidence-based. So many times, again, this may not be a major focus in today's presentation, not because evidence generation is not important, but then we needed to just have enough based on the time that we have. In terms of data, we are also interested in the epi data, because that guides us on the hotspots where we need to focus more. In addition, we have behavioral data that we also need to gather. And although this is important at all levels, that everything we do needs to be guided by some evidence, this will be discussed more in the next set of webinars. And then ensuring that we reinforce and strengthen local capacity and solutions. Most communities already have solutions to most of the problems that we see, and therefore what we need is to build their capacity to be able to manage it in the right way. And then collaboration, collaboration, collaboration. This is important, not just with other partners, but also among other responders, including the community. So in terms of definition, I'll not belabor this, because we have come across these definitions time and again. Just important to note that in terms of risk communication, we must always remember that we need to communicate providing real-time exchange of information, because the more when we delay, then we find that misconceptions and disinformation tends to fill that gap. And then community engagement that many times we do not pay attention to is a decision to involve the community in acting together. Most of the time we talk of RCCE, people think about IEC materials, which is more on the communicating part of it, but this should be coupled with actually interacting with the community. And as I've mentioned, this can happen at different points, so that it's not just for the RCCE person, but even community case management teams, RRTs, among others, end up engaging with the communities. So why is RCCE is important, or why should we bother with it? The importance is that, this is because it addresses low-risk perceptions. And I'm sure most people on this call are likely to have come across situations, whether it is in cholera or even other outbreaks such as the COVID-19, where despite the danger, you will find that the perception of the community is normally very low, and this needs to be addressed by engaging them, ensuring that they can trust us by listening to them and responding to their concerns. There's low or inadequate knowledge, of course, the mistrust that we are trying to address, infodemics in different formats, complacency, community resistance. I put a question mark here because sometimes when you talk resistance, then it sounds more negative. And then fatigue, there are uncertainties and fear. Sometimes they just don't just refuse to take the vaccine. Maybe they are uncertain about something, or they fear something, and these can be addressed through RCCE. Especially to be able to carry out the community engagement, there are certain principles that we need to put in place. Communicating in a timely manner that I've already alluded to. This promotes transparency, because when you delay with information, people tend to think that there's something you're hiding. So the sooner we talk about the issue, the better. We just need to be clear on what we already know, and if there's anything that is still not clear, we also need to mention that, you know, more is being researched around it. As soon as we have it, we'll be able to share. I've already alluded to listening. This is very important because the people we are dealing with are people, most of them are very well informed in some other forms, and therefore we need to listen to them, and that's the only way we can pick up the misperceptions, disinformation that is already out there, or whatever rumors there are. Planning with the community is important, again, for ownership and continuity. Even when the outbreak is over and the responders from outside have left, the community will continue to follow up on some of the interventions that really must continue throughout people's lives. If you take something like hand washing, for example, this should not just be emphasized during an outbreak. And if we look at most of the public health conditions, hand washing or hygiene always comes tops for most of them. We also need to ensure participation in all levels so that we are not just focusing at the health facility, but also in the community and also at the policy level. And then we need to empathize with this, try and fit into their shoes. Not a very easy thing, especially if you have not been in such a situation, but that is one of the things we try to work on. And if we do all this well, then we'll be building trust with the communities that we are working with. Further on the principles, it's important to note that all communication products and actions aimed at the community must be adapted to one setting, so that if you have communication products or actions or activities that we have put in place, the way we are going to communicate with people at the workplace will be very different from the way we interact with those in, say, a prison or a religious institution or learning institution. So we need to always contextualize our response, our interventions to the setting in which we find the people we need to reach out to. Obviously, we need to consider the level of education, age, sex, among others. The common languages and or dialects in the setting are also important. Most of the materials we have, especially those that we generate from the regional level or maybe headquarters, are likely to be in English or some other major languages. However, in some countries, you'll find that they have even more than 40 or even hundreds of languages. So we must always select the best that can reach majority. We may not be able to have the materials in all the languages or the messages. So the most appropriate means of communication for that team also needs to be used. If there are people who can hear, oral, written, even visual will be okay. However, for those who are hard of hearing, then oral may not work, and we may need to use the written and visual and even the sign language. Trusted and accessible channels and stakeholders need to be used, and then the materials need to be pre-tested before use and also before mass production. So for us to empower the community, we must build trust, get them to trust us, to be able to understand their perceptions. And then, as I mentioned, we need to empathize with them. And this empowers them to continue with activities even after we have moved out. So next, we'll just look at a few of the hows. Many times we know what needs to be done, but the how becomes problematic. So for example, we know we need to engage the community leaders, but how do we go about it? So it's important to consider the sociocultural as well as economic context of each community, so that you'll find that even in a country or even within a district, there might be some differences in what can be done. So we need to identify the official and natural leaders who are our gateway to that community. These leaders or officials could be religious, administrative, among others. Holding stakeholders meetings is also important, and this is, again, as I mentioned, to listen to and understand the community leaders' concerns, where as much as possible, also train these community leaders to be able to address the issues as we would want them addressed. Involving the community in decision-making that affects it for ownership and sustainability, which I've already alluded to. Holding evaluation and follow-up meetings. So we don't just go in and agree with them on what needs to be done and then leave it at that. It's always good to evaluate and see with the community what has worked, what hasn't, and maybe even agree on how to improve it later on. So giving feedback to the community helps to close the loop. We don't just get information and then go with it, but should be able to come back and share with them again. Then developing reports to document the process and activities. This is important, as we always hear, if it is not documented, then we can't be sure that it was done. So in terms of risk communication and community engagement during an outbreak, it's important to realize that it helps to quickly control the epidemic by keeping the community informed in time. Remember, the timeliness is key here, so that we don't leave any gaps where misinformation will find its way. It also helps to reduce the risk of spreading disease as we share activities that can be done to ensure that we cut the transmission. And then raising awareness about personal protection and prevention measures is also key to ensure that people remain safe. And in this case, public health professionals such as the rapid response teams should also report any cases or suspected cases and what they do when a case is admitted to hospital. This is important. So again, we don't have the kind of rumors that we keep hearing about people's organs being harvested or some other negative messages. So if as a communication team, we know where the suspected cases are, possibly they are still waiting for the lab results, then we are able to engage with the larger family or even the community at large. So how do we communicate about the outbreaks? It is important to talk about the event. If it is cholera, you need to say a little more. How did it start? How serious is it? Sometimes we assume that everybody now knows that cholera is serious and we should be concerned about it. However, we know that in the communities where we live, sometimes we have other more pressing issues, so that if you're telling me not to, for example, touch my mother who is sick, and yet I'm the only one who is there, what does that mean? Or if I'm unwell and I feel that I need to go out and earn a living, how then do we talk about this? And this will be determined based on the evidence that we have, so that we are able to address each case as it comes up. The risk, how dangerous is it? Are we at risk, me and my loved ones? Who is most affected? And what is it that is likely to increase the risk or decrease the risk, whether to me or others? Then the actions that can be taken. What is it we can do to prevent getting sick at an individual level? And also, if I'm taking care of my family, then what is it that I should do to ensure that my family remains safe? And then, as mentioned earlier, it is important to evaluate and also monitor the results based on what has been done, what has been achieved in terms of the objectives, what lessons have we learned, and what are the challenges. Then on reaching out, communication channels is an important one, and I'll not spend time in this because this is a common topic. And this slide just has examples such as reaching these audiences. As I mentioned again, the setting is important, and all those in different settings can actually be considered a community. Then we have government, civil society, among others. So for the community, we can reach them through home visits, mass communication. This could be through a community radio if available, especially when we are considering the language or even the cultural aspect. Educational talks are common, and those in hospitals sometimes have become so routine that maybe people do not pay much attention. So we need to keep revising and using evidence that becomes available. So in short, we need to use any opportunity available to communicate about the risk, most importantly by engaging the community so that whatever we are communicating responds to what their concerns are. So this is another that I may not necessarily go into too much detail about the disease. I've mentioned it in the previous one. Infection prevention and control, this one is key, and I've already mentioned hand washing, but it goes beyond that. We must focus our messaging around personal and environmental hygiene, because many times, again, our assumption is that if we tell the individual to wash their hands, they will be able to wash their hands, or tell them to use latrines, they will do it. However, the environmental part is also important. There are structural factors that determine whether people perform at behavior or not. So if those are lacking, then it becomes problematic. And this is why we then must work closely with other sectors, the multi-sectoral approach. Safe and dignified burial, this has become a big bone of contention, not just for cholera, but others. So we need to be very clear on the messaging that we need to provide to prepare people before even the deaths happen. Oral cholera vaccine demand generation is another area. In terms of treatment, again, we need to focus on the need to seek care early. This has been a major problem where we find many people reporting to hospitals when it is too late with serious dehydration. The importance of home as well as the oral rehydration points is something that we also need to emphasize. Also talking to people about what to expect at the CTU, CTCs. Many people tend to think that it's not important, and especially when we have rumors circulating, then it becomes problematic. But they need to understand that especially with dehydration, they need special attention, and that can help them get better faster and avoid adverse or serious consequences such as internal organ damage, among others. The last bullet is important because many a times this is overlooked, the mental health and psychosocial support. This is very key, especially in the initial stages when people suddenly overwhelm the hospitals and then they are discharged back into the community after the community has been told not to handle them and to be careful, among others. So this is an area that we need to focus on, especially once we have an outbreak, but can actually prepare people even earlier. Also carefully considering the establishment of decentralized care. This has been done in most of the countries in the current outbreaks. However, there are situations when the team arrives there to put up some of these structures without having interacted with the community. So our suggestion here is that conducting two-way dialogue with the community members is important to scope acceptability and co-designing so that we don't have situations where the community brings down the CTU or the CTC. So sharing community feedback and perceptions is key to ensuring that these can be contained within the communities. Then community dialogue for clear messaging on effective versus harmful cholera treatment. Again, whatever is in this bracket is just an example. I'm sure we have come across many remedies that people are promoting that don't necessarily work. So we need to find ways of addressing those. Promote case identification and referral through the community-based workers. And I've seen that in some countries, even individuals are encouraged to report cases that they suspect, and then the responders move in to address the situation. Then in terms of IPC, sorry. So we need to work with herbalists and integrate ORS, purchased or homemade, and adapt traditional remedies. Encouraging these people, in some countries, they actually have organizations where they meet and have discussions. And so as health workers, we need to work closely with them and encourage them to refer patients to facility-based care. And in terms of ORS, these are people who can be used. ORPs can actually be set up in these areas, because in many communities, we know that a good number of people start off there. So their capacity needs to be built. And then engaging a wide range of biomedical providers. We know that many people will go to a shop and buy medication. And so these need to be aware and also ensure that they can refer their clients to the facility-based care. And then for urban residents, we also know that they are very likely to seek care first from the drug shops or pharmacies. Many people tend to want to avoid the hospital. So still on IPC, having prevention control task teams that are drawn from existing community structures. Where there's a community structure, we have community health workers, among others. These should be used as opposed to going in and starting over at the beginning. Advocacy is key. Again, multi-sectoral collaboration is key. Engaging trusted local influencers, very important. And then community participation, as mentioned earlier, is also key in designing locally appropriate hand washing stations. And of course, also interacting with those who need to provide the water or the sanitation facilities. Conducting case area targeted interventions. Earlier on the data and evidence, I mentioned that we need epi data, and this is what helps us identify the areas to target. Emphasis of structural causes of cholera, I already alluded to this, where for people to wash hands, there must be water and there must be hand washing stations, there must be soap or an alternative. And then a tailored home IPC kit can be constituted. This, I think, would be important, especially where we have maybe members of the family getting sick. Definitely other members will want to take care of them, and possibly if they have something to, some PPE of some sort, then they are able to handle their family members before the specialized care arrives. Then training community health workers and household members on the use of chlorine and other substances for disinfection and water purification. Many times people may have water that is not necessarily safe. And then consider local and religious funeral practices. This is for safe and dignified burials, which I already mentioned, that has been a real major issue in the recent past, not that just with cholera, but also with other situations. There are many rituals that are conducted, either religious or cultural, and again, people can be engaged and these addressed. Where possible, allow family members to join in most, or especially the cleaning and the like. Finding alternatives to the rituals is important, and also community dialogue, so that these are discussed for people to understand the importance of having the safe burial and also acceptance of adaptations of the rituals. Ensuring respectful and transparent preparation of bodies is important. And again, here it's important to include family or a trusted community or religious leader who can give feedback to the rest of the family or the rest of the community. Engaging organizers of funeral feasts to ensure hygiene And this is, of course, something that is cultural. However, working together with the families or communities can ensure the best way to handle it. There are situations where it may not even be possible to provide a hygienic environment, and therefore, in such a case, they need to be informed of why it will not be possible to have a feast in such a situation, holding the funeral and burial as quickly as possible once most of these have been addressed. Then there are others that, again, I'll not spend too much time on. I've already mentioned at length hand hygiene, use of latrines. There's the observation of food hygiene that also comes in that feasting at the funerals, but also in other situations. Ensuring that food is cooked thoroughly and kept well. Maybe not in a fridge, although in bracket, if one has a fridge, fine. If not, then there are other ways. And this is why context is important. If we are somewhere in the village, we just need to encourage them to cover that food. And then avoiding the handling of people who died of cholera and avoid distributing food during the ceremony. So as I conclude, just to remind ourselves that it is essential RCC is essential for driving change in behavior or practice within communities, but just to remember also that in addition, the structures must provide a conducive environment to be able to do this. So developing a strategy in collaboration with the community is important to ensure implementation of that strategy. It is essential at all levels of intervention, preparation, response, monitoring, and levels of influence, whether it is at a personal level or working with people close to us at the organizational level, maybe a prison or a school, and also at the community, and even broadly the society. And then RCCE, when done well, helps to build trust among the populations in the health response by managing the rumors and misinformation as well as possible. So again, as I mentioned, most of the infodemics, management of rumors and misinformation, we will be addressing this at a later date in the preparedness webinars, but it is also important because some of these rumors actually come up during the response. So that will be it for me. However, when you receive the slides later on, in the next few slides, these two just showing some modifications of what can be done or innovations. And then the very last two slides have some resources that are available. Again, for this one, we'll be talking a little more about it later on in the preparedness webinar. And then since between March and April, the RCCE team conducted a number of webinars, and the links again are on that last slide. Feel free to look at them and listen to some of the experts around community engagement. Thank you very much, and over to you, Olaolu or Prof. Thank you.
Oh, thank you so much, Susan, for that very interesting presentation. We're able to bring the whole concept within this short period. Really, thank you so much. Risk communication community engagement is a very important pillar in the response. No matter the science, if the community don't accept it, if we don't know how to pass the message across, then we'll not be able to move on with the intervention. So thank you so much. Not seeing any hand raised yet, but there have been some questions that have been asked in the Q&A chat, and some of them have been responded to. There's one particular one in French. I just tried to translate. Probably you could just deal with it because this is really what we may see that we usually see within a response. So the question goes thus. In case of resistance from the community during cholera response, what strategy can we apply to get this community to adhere to the response activities? So this is from Dr. Fabrice from the Democratic Republic of Congo. I think that question, you could just deal with this question. Over to you.
Um, Thank you very much, Olaolu, and thank you, Fabrice, for the question. In terms of community resistance, the best way to address this normally is engaging that specific community. Sometimes it's difficult to say that this is the specific way that we are prescribing to address the issue. When there's that resistance, we need to understand the reasons why that resistance is there. It reminds me of something that is commonly mentioned, about people refusing to take vaccines as an example, or in the case where there were people resisting having the cholera treatment centers. As I mentioned earlier, it is important to be very closely interacting with the community so that we understand what their concerns are. So in this case, depending on why that resistance is there, we need to address that underlying factor that is leading to the resistance. Is it something that they are hearing? Is it something that is just a perception and maybe is not an issue? Or has somebody possibly told them what needs to be done? So the short of it, or the way I would address this, is that we must understand the reason why they are refusing that support. Of course, in the past, we have had many reasons why people are resisting. Sometimes it's lack of trust, either of the government or of the responders. What is causing that mistrust is important to get to know so that that issue is addressed. So a lot will depend on the context and the underlying reasons why the community is resisting. Thank you.
Yeah, thank you so much, Susan. We have one hand raised. We have Simplis Otuta. Your hand is raised. You may speak. Can you unmute your mic? Simplis Motuta. Yes. Simplis, yes, you can speak. Just unmute your device.
Bonjour.
Yes, please unmute. We can't hear you. Simply, I can't hear you over here. Okay, could we just quickly take Oluwada for Aderemi? Oluwadapo. Oluwadolapo Aderemi, please speak. Could you unmute your mic? Yes, Oluwadolapo, I can't hear you. Oh, seems there's some connection issues. Please, in the interest of time, probably if you could just type in the questions in the Q&A chat, we'll be able to take those questions. We're a bit pressed for time. I can also see Emi Tuta. Let's just quickly try if you can speak. Okay, I think the hand is dropped. So please, in the interest of time, just typing into the chat box. We'll move to the next presentation, which will be taken by Rina Doshi, and it will be on reactive vaccination with oral cholera vaccines. So Rina, you could come over. Thank you so much, Susan, for the presentation. Rina, over to you.
Hopefully everybody can see the presentation. Okay, great, and everyone can hear me. So my name is Rena Doshi. I am the Immunization and Emergencies Officer here at AFRO, and I'm going to be talking about reactive vaccination and really just more general use of oral cholera vaccines during emergencies. So just a reminder, because I know that we have gone into this in the series, the webinar series, there are 5 pillars that form the basis of prevention and control of cholera, and the use of oral cholera vaccine is one of them. So OCV is important, but it's complementary to other prevention and control measures, and it can be used to contain ongoing outbreaks, limit the spread of an outbreak into new areas, and it can also provide this window where you can then implement longer-term cholera prevention and control activities such as WASH and community engagement, which we just discussed a bit about. So just a brief intro to the vaccines. So injectable vaccines have actually been around for a long time, since 1991. But more recently, there were 2 oral vaccines that were WHO pre-qualified in 2011 and 2017. So these were really game changers in terms of cholera prevention, because they're affordable, they're easy to use, and they've been demonstrated to stop or prevent outbreaks. They can also provide short and medium-term impact by boosting immunity. However, the long-term impact is limited because of waning protection, and I'll talk about that in a minute. It's really important, again, I can't say this enough, to use OCV in conjunction with other WASH activities and bridge that gap towards universal access to clean water. So the global OCV stockpile was created in 2013. It's supported by Gavi, the Vaccine Alliance, and the International Coordinating Group on Vaccine Provision oversees the management of all of the global stockpiles of emergency vaccines, cholera being one of them. There are members from 4 different organizations. The global OCV stockpile, which I think many know, is currently strained and not expected to increase until at least 2025. So ICG has temporarily shifted from 2-dose campaigns to support 1-dose campaigns until that supply increases. So just a little bit about the characteristics in the global stockpile, and you'll be provided with more detailed information on this when the slides are given to you. But there are 3 pre-qualified vaccines, 2 are in the stockpile. The vaccine formulation is an oral killed wholesale bivalent vaccines with 2 serotypes. The dosing administration, so as mentioned before, it's 2 doses given at minimum 2 weeks apart, up to 6 months apart, and it's oral, you drink all the contents. The eligible population is anybody greater than 1 year, including pregnant women and immunosuppressed persons, and there's really been no serious adverse events reported. Very minor side effects such as vomiting, very mild gastro discomfort, mild diarrhea. And just important to note that Shankle will not be supported after 2023, and there'll only be one vaccine available in the stockpile. So I wanted to touch on the OCV effectiveness and durability, and this is really important because it has implications for how you use the vaccine. So the 2-dose administration was shown to be 76% effective, actually 58% efficacy from randomized control trials. Protection is about up to 3 years. However, as mentioned, ICG has shifted to this 1-dose administration, and the effectiveness has shown to be about 40% for all cholera episodes. And protection is up to 6 months, although studies are ongoing and it could be longer, but it's important to take that into consideration when you're planning on using the vaccine. It's also less effective in children less than 5 years of age. So I wanted to get everybody participating and set up a poll. So, and just reiterate why we might use OCV during an outbreak. So if you could bring up the poll. Great. So we'll just give everyone a few seconds to answer this poll, see who's participating. Why use OCV during an outbreak? So I'm seeing some differing answers. Just give it a few more seconds. So I think we can stop. We have about 76 answers at this stage. So it looks like we have a consensus with 62% saying A, B, and C. And then we have some people who are saying just A, just B, or just C. So A provides rapid protection to at-risk populations. Yep, that's true. It can limit cholera spread into new areas, such as neighboring communities, also true. And C, OCV provides a window to implement longer-term prevention and control activities, also true. So thanks for participating. So OCV can be used in different situations. We're really going to focus today on reactive. However, it can be used as preemptive during humanitarian crises or man-made natural disasters. And for that, you would access the ICG stockpile. Now, during an outbreak, you would also access the ICG stockpile. And I'm not going to focus on preventative and planned vaccination, and that will be covered in another webinar. However, preventative and planned would be provided to people living in those PAMIs or hotspots, which has been discussed. So vaccination should not disrupt the provision of other high priority health interventions to control or prevent cholera. And targeted geographic areas and populations should be clearly identified by an assessment of current and historical epi data. So what does the cholera outbreak look like now? And what did it look like over the last 10 years? Maybe the country did not have cholera, maybe it did. Vaccination should also cover as many eligible people as quickly as possible. And really, an OCV campaign is most effective during the early outbreak stages where it can be used to help break chains of transmission, saving lives. So just looking at the epi curve on the screen, if we were to implement OCV early on around week 4 or 5 when we just detected cholera cases, maybe our epi curve would look different. Maybe we wouldn't see that high peak of cases around week 11, 12. If we implemented it late around week 21, it might have minimal impact. And not to say that it wouldn't have any impact, because it really depends on whether this is an epi curve at the national level or a district level. So I don't want to discourage anybody from utilizing it, even if the epi curve does look like this. It's important to just discuss it and look at all of the data combined, and we'll talk about that in a second. So there are numerous vaccination strategies that are used for vaccination, and OCV is really no different. So there's the fixed sites, and you might use this when you vaccinate an entire village or city. There's the mobile teams where you might use this with small populations who are targeted, and the number of expected people can be vaccinated within a few hours, kind of like schools. And also, it targets people who are unable to get to those fixed vaccination points or health centers during the day, like those who are working. And then, of course, there's door-to-door. And this could be used when there's a previous experience, such as with polio, which is also oral, and can be used for specific subpopulations, maybe a neighborhood, or those unable to walk to those fixed sites. So how do you access the OCV doses? So in emergency situations, you would request the doses to the ICG Secretariat. So that includes the request form, and then an Excel spreadsheet with 4 annexes, which includes the epi information, the history of previous outbreaks, laboratory information, and estimate of vaccine needs. All of that must be included, in addition to a vaccination plan, map of the areas to be vaccinated, and the Gavi budget template. Now, if you are a Gavi eligible country, this is critical. And this is how operational costs would be covered. The decisions are usually made within 72 hours, although it's important to note you may be requested to provide additional information. For example, if you didn't provide enough historical information or you didn't provide maps. And then reactive campaigns can be used for outbreak response or preemptive in humanitarian settings, as I mentioned. One request serves one campaign, so feel free to submit multiple requests as the outbreak evolves. And I'm not going to talk about non-emergency situations, but I wanted you to have this, and I wanted to highlight that if applying for preventative vaccination doses, you would need to develop your multi-year plan of action. And again, that will be discussed in subsequent webinars. So what are the minimum requirements for an ICG request? I just went over it, but let's talk about it a little bit in more detail. So you do need to have a laboratory confirmed case of cholera if you would like to use OCV during an outbreak. You'll have to provide laboratory information. The request form with current historical and epidemiological cholera situation. So you need to describe the epi of what's happening in the country, the person, place, and time. You also need to demonstrate the risk of extension, and in the case of a humanitarian request, the risk of an outbreak. So are you worried that this outbreak is going to spread because there are mobile populations or because the neighboring area has poor sanitation? These are things that you should be describing in the request. The vaccination plan should be included along with a description of infrastructure and capacity, meaning can you implement the campaign quickly? Also, confirmation that the OCV campaign has not been conducted in the previous 2 years in the same area. And this is important merely because we're working with a very limited amount of doses. And then, of course, it should be reviewed and agreed by the National Health Authority. And it's recommended that OCV requests are submitted to the ICG Secretariat within 7 days after confirmation of an outbreak. So once you have that confirmed case, and if you think that it's going to be cholera, start preparing that ICG request. Ensuring that the request is high quality can also make the process of approvals and receiving doses much more timely. So the ICG process to release emergency doses, I won't go into detail, but once it's submitted, it's circulated, and then the decision should be in 48 hours after the circulation. Approval, then that goes through procurement, and in theory, vaccines should arrive in country within 10 days. Again, this can take much longer though if there's requests for additional information. So I wanted to talk about what's going on and how we can improve impact on the utilization of OCV. So first of all, it's recommended that a country submit their request within 7 days of an outbreak. That's actually not happening. The median days, and this is just based on 11 countries and 20 requests in 2022, was 55 days. So 0% were on target. So this is something we can work on. And one thing to note is if a country has already submitted one request in the past, you can use that to populate the next request. And then the other place that I wanted to highlight is the campaign start after receiving the vaccines. So in theory, we would like to see the campaign start within 10 days. 21% are on target, and the median was 29 days. So this is another place where we can see improvements. And we'll talk about what we can do to improve this. So I just wanted to give a brief overview of the OCV stock, the requests, campaigns in 2023. So for all of 2023, up to the end of the year, there's about 37 million doses available. At the end of August, 52 million doses have been requested. 21 million doses have been shipped. There are still 17 million preventative vaccination doses still pending. And we're short about 50 million doses. Here's OCV usage by country from 2013 to 2023. You can see the AFRO countries are in orange. And I wanted to highlight that other countries are also utilizing OCV, although not as frequently as most of the outbreaks are here. So now I want to talk about some of the challenges and what we can do. So ICG requests for outbreak response require laboratory confirmation. So it's important that that is done before the submission, except in humanitarian situations, which we're not going into a lot of detail. So a lot of the requests have this limited review of the epidemic situation and real justification for the areas of vaccinations. So sometimes the requests will have all districts. Well, the request should have all districts and not just the targeted districts. Some requests will have missing district level epidemic curves, which is also important. And then no maps. Also, the risk of spread. This needs to be clearly articulated. Examples including what is the population density? Are there any IDP camps? What is the WASH situation in these areas? The case management situation, the health facility plans, all of that should be well described so that the members can evaluate the risk of spread. Also, what is the feasibility of the campaign? You need to review historical OCV campaigns if there have been in country, and that should be well documented in the request. And then another thing that delays things is delayed budgets. And also important, if Gavi eligible, use the template. That's really important because eventually you're going to have to put it into the template. And I just want to say, sharing in the chat, what other challenges do you have or do you foresee with this? Please share so that we can share experiences. So again, going back to this late implementation of OCV campaigns. So why is this happening? Well, of course, there's always delays or difficulties in detecting and confirming outbreaks due to surveillance and diagnostic capacity, but also campaign preparation. So don't wait until the doses arrive. You can plan early. While the ICG is making a decision, start thinking about what your campaign should look like. You've already provided a lot of that information with the request, so it should be quite easy to start thinking about how to implement. Also, make sure that the EPI team is involved. This is critical because they plan campaigns all of the time. Consider combined OCV and WASH activities. This is important for long-term prevention and control. And start early, and it's great that I followed the RCCE presentation because this is critical, and oftentimes enough isn't allocated in the budget for these activities. And it's important to think about that because building vaccine confidence and demand are critical to a successful campaign. So begin those activities early. Also plan for monitoring and evaluation, such as coverage surveys and impact assessments. So again, if you can think of any additional challenges, please share them in the chat. So in summary, OCV is complementary to other prevention and control measures and can be used during cholera outbreaks. But a constrained OCV supply does mean that we have to carefully prioritize targeted areas for vaccination. And also important to reiterate again and again that reactive vaccination should begin early for the most impact and most life saves. And that's our goal. And just some pictures of trainings that have been conducted, week-long trainings regarding OCV. Thank you so much.
Great. Thank you so much, Rina, for that excellent presentation. Thank you for bringing the importance of the oral cholera vaccine and really get it done quickly within an outbreak situation. 10 days, just 21% of countries have been able to meet that target. So this is an area that really need to work more in the country. Before I go to the hands raised, I've seen two questions which I just want you to note before let's take one oral question. So one is, why will Shankle no longer be used after 2023? Is it still related to the worldwide shortage? Then a question from Mohammed is, what's the vaccine management specific needs for the oral cholera vaccine, such as temperature needs? So going to, I think there's a hand raised, which I think the hand is now down. Okay, so Rina, I guess you could just take these two questions. Over to you.
I meant to share, apologies. I wanted to share more details on the vaccine. So let me pop up my screen again. Okay, hopefully we can see this. So this is more detailed characteristics of the OCV in the stockpile. So there's two vaccines, so not supported after the end of this year. And you can see that there's a huge price difference in terms of the two vaccines. So that is definitely playing a part. And this makes more sense. But one thing I do want to note that I didn't mention related to the two vaccines is that really demonstrating your need in countries is important as we try to advocate to increase the global supply. So that's a really important key point that I want you to think about, and also will come into play in subsequent webinars with when we discuss preventative vaccination. Just the next question.
Okay, yeah, Rina, so could you elaborate more on the booster cholera dose?
The booster cholera dose?
Yes, and that's a participant asked for that, yeah.
Sure. So the other issue with the booster, so both vaccines are essentially the same vaccine, same formulation and everything. And they both are a 2-dose regimen, just like many other vaccines. So the second dose should be given at 2 weeks or more after the first dose. Now, because of the supply constraints, ICG has moved to this one-dose strategy. That doesn't mean that we wouldn't want to use the 2 doses. It's just based on supply constraints and provides this 6-month window where you can implement control strategies. But it is a 2-dose regimen.
Okay, Rina, are you still there?
Yep.
Okay, okay. Thank you so much for the responses, and colleagues I should be available to really type in some of the responses for those that are on the chat. So you'll be getting your responses shortly. So thank you, Rina, for that. And just for us to know that the vaccines are essentially a stopgap, as we've seen in the poll that we just took. Essentially, we want water, sanitation, and hygiene to really be things that all countries have so that we can actually prevent cholera outbreaks from occurring. So thank you, Rina, for the presentation. We'll now move to the next presenter, and we'll be looking at the overview of cholera kits models, introduction to the cholera kits, that to be taken by Miguel Serra. So Miguel, over to you.
Mikel, you are muted.
Yes, this is Mikel, working in the Nairobi hub in logistics, OSL, and in the supply team. So I will be presenting this presentation about cholera kits, the content, and the use of these cholera kits. Marachi, please, can you share the presentation? Okay, thank you. So next slide, please. So as I was telling, this is to get familiar with cholera kits, all the modules, and understand why we need to order one or another module of these kits. Next slide. Okay, to start to understand the cholera kits, we have to go to the beginning. So the father of these kits came with 2005. Was created the IDD kits, this interagency diarrheal disease kit that was for 500 patients, so 400 moderate and 100 severe. And this, with experience in the field, we realized that was not really adapted. So in Zimbabwe, Haiti, and Sierra Leone, the team in the field, they realized that this kit was not the best one. So that's why in 2013, the WHO organized a meeting with experts like UNICEF, IFRC, MSF to review this kit and to create what we know now as a cholera kit. Next slide. Okay, so this was when the kit was born, was in the catalog since 2016, were the revised kits, and this kit is going to be revised every 4 years. So now we have the 2020 version of these kits. So, and what is these kits about? The difference with these kits and the previous one is that these kits are more flexible. So, they are not so big. It's for 100 patients, not for 500 like the other one. So it can be easy to adapt to different contexts and to be easy to distribute it. So this is the main point of these kits. And apart from the kits, also was created a cholera toolkit to calculate the number of kits we need. So the description of the 6 main cholera kits, we have 3 cholera treatment kits. This is one we call cholera central, cholera peripheral, and cholera community. This is for treatment. We have a hardware kit that provides all necessary to create a CTU or CTC. And the other 2 kits are for alert and surveillance, is a cholera investigation kits, a laboratory kit. So let's go. No, this is for 100 samples each. Let's go one by one. Let's start with the investigation kit. Investigation kit is what we need to take some samples. Is for 10 samples. And now the difference maybe is that increase the number of RDTs. So we have now 20 RDTs in these kits. It's just a box. This kit is not a big one. It's just a box. We have a carry blare, we have swabs, and stool containers in the kits, apart from the globes, markers, and the important also is that packaging for biological substance is a triple box. We have 5 of them. Of course, if we need more RDTs, we can order RDTs, the quantity what we want, but apart from the kits. So the kits come only with 20 RDTs. So if we need more, we can order more. Next slide. Now, this one is important laboratory kit because this is to confirm the presence of Vibrio in laboratory. So after the alert and the suspect, we need to confirm, and this kit, then we need to know what is from the kit. We have antibiotic dish, culture medium, consumables, and reagents. So before to order the kit, we have to know what exactly is needed in the laboratory. Because please don't. Because sometimes these kits are not completely adapted to each country, so we need to talk to the laboratory specialist and tell us what we need exactly. And also we have to take account that this kit is 2 to 8 degrees, so we need to take in account this is called it's a cold chain, and it's a short shell life. So don't order a lot of kits, because some people order 100 of these kits. It's not possible. It's not a good idea. So it's between 5 and 10 kits is more than enough for laboratory kits, and then we can order more. Okay, next, please. Okay, now for treatment kits, this is the mother of the kits, because with these kits, we need all necessary to treat these cases. So we need, we have 3 different kits, depending on the number of patients. I mean, if they are moderate or they are severe cases. For community, we just deal with moderate cases. It's 100 moderate cases. For periphery is 400 severe cases and 60 moderate. For central is 80 and 20. So the proportion change depending on the context. So we can call these urban settings, or these urban or these closed settings, or these are different village, for example. So next, please. Now, this is the summary of these 3 kits. Every kit have different modules. So we can see that there are 5 modules, but now the 5th module, the documents module, is not there anymore. And the community kit is just having 2 modules. So this is the summary of each kit. Next. Okay, this is the content of the kits. For community, we have 2 different parts. It's a part is logistical, and another one is medical. So the drug module of this part is ORS and zinc and water purification tablets. Also, there is no ringers here because it's just for moderate cases. And there is the ORP module, the oral radiation point, also with all the necessary to put clean water to drink and to make the ORS for the cases. So this is for 40 patients maximum per day in a place that you should have tables and chairs, because in the kits there is not included the tables and chairs. So we have to take in account that we have to use structures to set up these ORPs. Next. Okay, periphery cholera kit. This now is divided by 4 modules. The first one is the drugs. This module is the more heaviest one because they have a lot of ringers, of course. We have ORS, we have azithromycin, doxycycline, all these that you know already, paracetamol, and etc. Module 2 is renewables, all necessary for inject these ringers, cannulas mostly is more important. Even cannula is here that we already found in the investigation kits. There are also body bags in the renewables, and gloves, and even fecal collection containers. Next, equipment is module 3, and we have here the things that not expired. Is scales and scissors, stethoscopes, monitor, and glucometer was here before, but now is not there anymore. So the glucometer is now a part. Next slide. Another module of this kit is logistic. This is the biggest one and heaviest because a lot of items. We have sprayers, we have cholera beds, we have buckets, solar lamps, etc. So what was before called Module 5, these documents and stationery, now just comes with a USB flash, is included in the box 1 in the drug module. So the Module 5 disappeared in 2020 version of the cholera kits. So now we just having this USB flash drive. Next. Okay, now central cholera kit is more or less slightly the same that peripheral kit, but quantities are bigger because we have more patients, in severe patients that need more ringers. So that's why we will have more quantity of some items. So this is quite similar. Next. The same for logistic module, that we have more chlorine, we have more cholera beds, we have more solar lamps, but essentially the items are more or less the same. Next. Okay, now we go to the hardware kit. This is OSL. I advise you don't order this kit if you don't have OSL team in your field, because this without OSL we cannot do much thing. We need to set up CTC with this hardware kit, and we need to start setting up tents. Here in this kit, we have 3 tents of 42 square meters and 2 tents of 27 square meters. That makes a capacity for 42 patients. And there is a water module as well with 4 bladders of 5,000 liters. That makes a total of 20,000 liters for 100 patients per day, because one patient is 60 liters. So 60 liters times 100 is 60,000 liters, times 3 is 18,000 liters. So that's why it makes 20,000 for 100 patients. For sanitation module 6.3, we have squatting plates to set up latrines for 4 for patients and 2 for staff. We have also plastic sheeting, 3 rolls, and yellow biohazard bags. Next. So the hardware kit have now totally, there was before 5 modules. Now we have more modules because we include motor pump module and water tool box module. So there are 7 modules totally now. The support module also we have cholera beds and solar lamps. And the fencing module is plastic, or just plastic sheeting, no? So 5 rows of plastic sheeting, and we include now in the 2020 kit motor pump and water tool box module. Next. Okay, so the difference of this new 2020 cholera kit is that the glucometer module is a part, so it's not coming with the equipment module. We have these 2 modules on the hardware kit, as I told you now, and disappear the IEC hardwares. Now it becomes with a USB stick. Next. Okay, some information that maybe is important, that is for logistic kits, for example. Not always we are going to receive the same, because depending on the availability of the suppliers, sometimes we can receive one branch and other times another branch, depending on the supply, because we have different suppliers that provide these kits. So you have to check every time that you receive the kits to see what is inside and what is exactly what is in the packing list. So the only item that expires in the logistic kits is the sodium dichloroisomerate, is the chlorine. So this is the only one expired in this module. Taking account that most of these items can be bought locally, manufactured, as the cholera beds. You see in the picture that I put some cholera beds were manufactured in Malawi. So sometimes it's better not to order everything from kits and do local purchase and manufacture also locally. Los solar lamps and cholera beds can be found in logistic modules and the hardware kit as well, so you can find in both places. And even the pool tester and chlorine, also we can find it in the hardware kit, module X62, and the logistics modules. Next. More information for the cholera kits is that for the drug module, we have to take in account that the temperature should be controlled from 15 to 25 degrees when the transport and during the storage. So, and depending on the weight and the emergency, we can decide to ship it by plane or by sea, or by road, depending on where we are. So this is a decision that should be done depending on the budget and depending on the emergency of this. And taking account as well that the hardware kit is very heavy, it's 2.5 tons and bulky and expensive. So that's why the cholera should be ordered in modules, not completely. Depending on the needs in the field, you will order more modules or less modules, but not the full kit all the time. So ringers also in the modular drug is very heavy, 640 kilos only for the ringers. Next. And this also, every time that you receive a cholera kit, you will see this label, this orange color, and there is some information that is important to see and to read, is that you can see here which kind of cholera kit, in this case is Cholera Central, is in brackets, Cholera Central, which module, so can be module drugs, can be module logistics, can be module renewable. So we see also 1.1, 1.2, 1.3, it's a 1.4. And then how many boxes? Here we have 3 boxes of 9. So this is the number of boxes that we have in total in the kit. Now they have also the code of the module, and the first item to expire. There is the first item to expire and the weight and volume of the boxes on the right side at the bottom. Next. Okay, this is the bibliography that you can read more information, because this information is available in this WHO site and open courses, so you can see all this information available and you can complete if something missing or you need more information. Thank you, and this is all from my side. Thank you for questions.
Great. Thank you so much, Miguel, for that presentation. Thank you for letting colleagues know how WHO supports countries to be able to get logistic needs. And this is just to enlighten the member states on how these items are moved, which is really functional. You talked about the number of patients that a particular kit will take care of, and also for investigations and all that. So thank you, Miguel, for the presentation. Going to the chat, not seen any hand raised. I have not seen any specific question addressed to you. Some are the ones addressed to the earlier colleagues. Oh, okay, we have James. James, kindly unmute your device and ask your question.
Yeah, okay, thank you. I'm just trying to ask about the issue of the tents in the cholera center and the beds for the cholera center and other things. What could be the way forward after when the cholera is stabilized?
Okay, great. Thank you so much, James, for that. We have Abubakar Sadiq Papa. Unmute your device. Yes, Abubakar, kindly unmute your device to speak. Yes, Abubakar, you can speak. Your mic is open. Hello, Abubakar, can you hear me? It seems maybe there's an issue with your device. It's open here, but we can hear you. Okay, we can. Okay, speak on. Okay, we have Balarabe Salisu Garko.
Hello, good
Hello,
morning, sir.
Yes, good morning. Go ahead with
Okay,
your question.
okay, thank you, sir, for the wonderful and educative presentation. So, based on the presentation of the cholera kit, I have come to understand that there is many other equipment used in the place or in the area where there is a cholera and where cholera activities will be carried out. So, sir, my question is that uh, there is some equipment mentioned that can be reused again. So my question goes to: is there are the equipment being reused? Some of them are they being reused after the specific activities carried out in a place, or they are all discardable? I mean, can they all be discarded so that to use it whenever there is another activity?
Okay, okay, thank you, Balarabe. I think, have you ended your question? Okay, great. Thank you. Abubakar Sadiq, your hand is still locked, and can you speak through your device now? Yes, Abubakar Sadiq. Okay, maybe let's just take those two questions.
Okay, let me see if I understood. The first one, for the beds, cholera beds, and set up a CTC, taking account that the hardware kit just allow us to set up a CTU, maximum 40 beds. So that means that in case we need a large number of patients, we have 100, we need to set up a biggest one. So we will need then to order separate tents, 72 square meters tents, to allow a capacity of 20 beds per tent. So in cases that the outbreak is huge, the hardware kit is going to be small, or we need to order several shelters because it's not going to be enough for the beds and for tents. So I don't know if this answered this question, but this is what I understood. We need also to try to order locally beds, because the beds in the kits also are limited, so we cannot maybe satisfy with order all the beds we need. So we need to maybe to prepare more beds locally. Second one, I think that is understood is to be prepared for next outbreak is what we call e-prep. No, if we have already stored some items in the warehouse in the country, we can face next outbreak having, for example, what we can call CTU in a box. So all necessary to set up a CTU, like tents, like beds, like buckets, everything should be already there. Even we have to assess the local procurement, and we already know what is available, the prices, so we don't need to order every time international kits for everything. So we can just build this assessment for local procurement. And the next outbreak, we can already procure these items locally. So this is, I think, the questions I understood. So I don't know if something else is missing. Over to you.
Okay, so thank you so much, Miguel, for those responses. We have other panelists on the call that will also be giving some responses. So let me call on John Marcina, then Professor Bola would come in after.
Thank you so much, colleagues, and I hope you're able to hear me loud and clear. I think Miguel has addressed the questions very well. I think the other part was just alluding to the decommissioning protocol. And that's why it's very important as we set up the CTCs, we request for the tents, and we request for the supplies, all the reusable materials. And I think this should be adapted from country to country and also from the context where we are working from. But I think those are really great questions, and we've been having these discussions over how the decommissioning should be done. So as the teams are responding to the outbreak, they also have to think about how the decommissioning is going to be done, and this has become as an added cost that is usually not thought of at the start of the response. It becomes very easy to respond, but it becomes very difficult for you to pull out the response. So really good questions and really good concerns, and I think teams on the ground should really think about decommissioning even in within the response itself. And I think Miguel has given a very good response to that. So what you need to think about is just how are you going to decommission, where are we going to store these reusable items, so that we are prepared for the next outbreak as well. Thank you, and over to you.
Thank you, John.
Okay. Yeah, thank you. So let me allow Dr. Patrick to speak now. I'm not sure of his time, so Dr. Patrick, the floor is yours.
Thank you, and thanks, Miguel, for a very excellent presentation. I just wanted, from a general management perspective of a response, to make two comments, which are very critical. I think the commodities that Miguel has talked about are very important in terms of the outcomes in a response. And we are always trying to ensure that we keep the case fatality ratio below 1% as recommended by WHO. And for cholera, we know if you don't have the appropriate fluids to be able to for the severe cases, even to manage the moderate cases, you will have very high CFR. So it's always very important that at the start of the outbreak, that the countries quickly assess what resources, the supplies they have for management of both the moderate and severe, and quickly work to ensure that there is a steady supply chain of these commodities. And so requesting them based on appropriate calculation, using projections of how many moderate cases, how many severe cases, and ensuring that these are requested on time is very important. The second issue is around also balancing and aligning the utilization of this and the requests that are being made. Most of the time, once the initial supplies have been requested and delivered, there's nobody monitoring the utilization and aligning this with how many patients we have. It's very clear in terms of one kit will treat how many patients. But sometimes, because the healthcare workers are overwhelmed, you find that a kit that should have treated maybe 80 severe cases and 20 moderate is only treating maybe 40 severe cases, because the management, the clinical management is not appropriate. People are being, the fluid, the rational use is not happening. So it's something that the case management and the OSL people need to work to ensure that we are monitoring utilization and also ensuring that the supply is steady. The last one for me is the last mile delivery. So in most of these countries, you'll find that these supplies are stuck at the national medical stores or the national warehouses, and you go to the most remote health facility, and people are struggling. And we have seen situations where cholera cases have been managed with normal saline, with the resultant complication due to hypokalemia, and because the Ringer's lactate was not available at the facility level, at the field level. So it's very important to ensure that these kits, whether and the appropriate kits, it's a peripheral kit, it's a community kit, reach the places where they are required most, and we avoid ruptures, because for a cholera case, just a few hours is enough without appropriate rehydration for somebody to die. So I just wanted to emphasize those three. Thank you.
Thank you.
Thank you so much, Dr. Patrick. We have, Kate Alberti. Yes, I can see you online. Your hand is raised. You may speak.
Thank you very much. In fact, John Messina probably raised the critical points for me and the points that were raised. So just, pardon me, I should have introduced myself. My name is Kate Alberti, and I'm from the cholera team, WHO cholera team in Geneva. So I think what
Hi, Kate, we lost you.
Oh, seems we've lost Kate. So,
just in fact, am I back?
Yes.
I think I was just
okay,
Yes, you're back.
You're back.
Sorry, I think I switched into a panelist, and I think something got lost in translation. That's okay. So just saying, as John said, there is, Dr. Messina said, there's a whole process for decommissioning, which I think he emphasized correctly. So there are some materials that can be kept from one outbreak to another, but only if they have been disinfected properly and if they're stored correctly. Otherwise, what we tend to see, and again, Miguel can add to this, is if they're not stored properly, when you go back, you find that they're just not in a condition to be able to be used. The kits are the way they were designed was to be able to move them quickly. The ORP kit, for example, can even be split into two, each one, but there has to be that support to get them where they're needed, and I think that's one of the critical pieces. The kits, I apologize, I was in another meeting and came in a little bit late, but for the medical kits, they really are designed for slightly different context. The central kit is really designed that there is somebody that has the qualification to be able to give, for example, potassium, which is not included in the peripheral kit, where there's an expectation that there may not be a medical doctor present. So it is worth looking really at the content when you're ordering, and ordering in advance, so that we're there to be able to treat the first patients. And those that are the furthest away does require, as was said by Dr. Ramadan, that requires that organizational planning and logistical support. Thank you very much.
Okay, thank you so much, Kate, for those further explanations, so that colleagues will get. We have some more time, so there's still a hand raised. We have Basim to Mazal. You may kindly unmute your mic and ask your question.
Thank you. Hello.
Yeah, hello, we can hear you. Go ahead.
Okay. Please, I have one question for the last presentation.
Please go ahead.
Yes, about this presentation, I see peripheral cholera kit in module 3 equipment, and there I see glucometer with a tester strap, and I don't understand for why we're talking about cholera and we use a glucometer with a tester strap. Please, I need the more explication. Thank you.
Okay, thank you for that question. Yes, Miguel.
I think it's not a logistic question, but I understand that we separate this glucometer mostly for community, just to evaluate the sugar, but maybe a case management person can answer better than me for this use of this glucometer. Yeah. Maybe.
Yes, John Messina.
Yes, thank you so much. And I think it's a good question, and Miguel is trying to run away from it, and I think he has a valid point there. So we do have glucometers that are put as a separate addition to the peripheral kit. We all know that one of the biggest complications of cholera is hypoglycemia. So we want to support the peripheral facilities or the rural setup facilities to be able to detect hypoglycemia early, and also to be able to treat hypoglycemia as soon as possible, and that's why the glucometer kits have been added to the peripheral kit. It's just for early detection of the commonest complication of cholera and be able to treat. And usually what we encourage that even if we run out of the glucometer sticks and we don't have the glucometer as well, most of the patients with cholera are usually prone to hypoglycemia. So we are strictly encouraging that as soon as the patient is fully rehydrated, they are able to eat something, please encourage them to feed early. And we usually aim for 3 to 4 hours after correct rehydration. These patients should be allowed to eat something, so that we just prevent the issues of hypoglycemia. So it's basically just for the complication of hypoglycemia in cholera. Thank you, and over.
Oh, okay.
Yeah.
Thank you.
Thank you, Dr. Yeah. So thank you, Dr. John, for the extra explanation. Thank you, Miguel, for your lovely presentation which you've made. I will hand over to Professor Bola to come in and give more information on this session. Thank you for your participation. Over to you, Prof.
Okay, thank you, everyone. Thanks to all our panelists. Thanks also to the presenters, to the participants. We've had the series now for the past 3 weeks, but I'd like to tell you that this isn't the end of the cholera series. A lot of you have asked a lot of questions, which I'm sure will be answered in the forthcoming series. There are questions about vaccination. What criteria do you use to determine who needs to be vaccinated? Which communities are considered high risk and all that? And in the next coming weeks, there will be this series on cholera preparedness and cholera readiness. We have focused more on the response part in these past 3 weeks. And one of the reasons why we have focused on the response part in the past 3 weeks, if you look at the slide I'm trying to share, is just to remind us that in the WHO African region, we've had 15 countries affected over this past year or in this current year. And as of this week, we've had 142,579 cases reported, with 2,009 deaths, and the case fatality rate is above the 1%. It's been 1.4%. We also talked about the various contexts in which these outbreaks have been occurring. Now, considering the fact that this context in which the outbreaks have been occurring, like droughts, like floods, conflicts, and so on, are things that will still persist over the next few months, over the next few years, particularly in the AFRO region, then it means that there are things which we need to look at. Look at our epic curve, and you can see that we're not totally out of the outbreak yet, as we are still reporting significant number of cases on a weekly basis. So having said that, we want to round up this session by looking again at the core components of an effective response. We are talking about things like the necessity for emergency coordination. We know that with the COVID, there has been set up a lot of public health emergency operation centers around countries. There have been a lot of capacity building around emergency coordination, and this is critical. And then we also look at surveillance. Surveillance is a key component, the ability to detect early. And of course, we know it's detection that allows us to respond. So our epi surveillance and health information systems are laboratory diagnosis and testing systems. Cholera, we have said it over and over, is a preventable death. So we should not be recording mortalities from cholera. So what are case management structures? How do we ensure that we are able to provide safe and reliable care at all times, right from the beginning of the outbreaks? Sometimes what happens is that people are able to the care gets better as the outbreak progresses. But what we want now is that if there is an outbreak, the care right from the beginning should be quality and safe care. And this brings us to the infection prevention and control. Then protecting the community is important because that is one of the places where transmission really occurs for cholera. So how do we ensure our community is protected? How do we engage them? How do we communicate risk? How do we ensure that there's access to safe water, sanitation, and hygiene? And when there is a need for vaccination, how do we implement this? Then access to countermeasures. There have been a lot of reactions and to the last presentation, people just even beginning to know the contents of some of these kits and how it would help all our response. So having said all of this, we need to look at what will be our next steps. What do we do as a region? We cannot always be an outbreak forever. We have a goal for 2030. And so to round off this session, I'm going to call on Dr. Patrick, the IM, and he'll help us to close up this session. So over to you, Dr. Patrick.
Thank you very much, Professor Debola and the panelists, everybody who have been working tirelessly behind the scene for this very informative series of webinars. I would really like to thank the Cholera Incident Management Support Team at the regional office and our colleagues from the headquarters, the Cholera team led by Philippe and Kate and every. Oh, okay. I see my mic was muted. So thank you very much for all the work that has gone into this. I basically have 5 takeaway messages that I would like to re-emphasize in addition to what Prof. Bola has just summarized. Number 1 is that cholera is still a major public health threat in our region. We have 15 countries that have reported this year. We continue to see increased cross-border transmission in the Southern Africa between Malawi, Mozambique, Zambia, now also in the Western Central Africa between DRC, Zambia, and so there's a lot of cross-border transmission as well. And therefore, we are not safe as a region until we are able to bring the outbreaks under control in these countries. And we have to collectively work together in the response to contain, but also in terms of preparedness and implementation of the measures for cholera elimination within our region. The second one is that the cholera response in our region has largely been suboptimal. We have delayed detection, as was mentioned during the first series of the webinar. We have delayed confirmation. The lab capacity in most countries are not able to do culture, to do serotyping, to confirm which serotype we are dealing with. We have delayed initiation of response, resulting in high number of deaths. And we also have delayed initiation of other interventions like vaccination, as was presented by Rina. So we really need to get better at detection, improving our surveillance, strengthen our capacity in the labs to confirm, and ensuring that we are able to initiate the response early. Now, as a region, we adopted the 717 target to ensure that any new outbreak is detected within within 7 days and notified within 1 day, and comprehensive response initiated within 7 days. But even for cholera, as we know, with a very short incubation period. 7 days is even too much. If we are detecting within 7 days, the whole sub-county or county would have really been engulfed in an outbreak. So we need to do better. The third is that we have limited support for cholera response in countries. Most of our governments and even partners are not devoting sufficient resources to support cholera response. And as we have seen, you need a lot of resources to be able to contain these outbreaks. So now, previously, our cholera outbreaks used to last less than 71 days to contain. The current outbreaks, all these countries, most of them started in January. We are still now in September responding. So the time it is taking us to control the outbreak has significantly increased. And we really need to devote more resources to this and contain it. The fourth issue is that we are in the global community, and other countries, as was shown, are having outbreaks. And therefore, we have limited supply of the vaccine. And then we also have limited supply of the cholera kits that were just presented. So if we have bigger and many outbreaks, we will not have sufficient commodities to manage. And it's therefore critical that we also focus on prevention and focus on long-term wash investments that will help us to prevent cholera outbreaks. The last message is then what Professor Bola was talking about, which should now usher us into the next phase of the webinars, is that we need to go back to the GTFCC goal for elimination of cholera outbreaks by 2030 within our region. And we need to work as countries, we need to develop our national cholera plans, we need to fund them, we need to implement both the short-term, the medium-term, and long-term interventions that will help us to eliminate cholera outbreaks within our region. And I would like to urge all of you to be ambassadors of this message, and then request that you also participate in the next phase of webinars so that you get equipped with the relevant information that should help us to embark on that journey of cholera elimination within our region. I thank you very much. I salute you for making time to interact with us. And please, through our country offices, there are hubs, we remain available to support you. Just feel free to link with our country offices whenever there is any support required around cholera. Thank you.
Thank you, everyone. We'll see you at the next cholera webinar.